All right, I appreciate it. Okay. My name is Garrison Grant, and I will be presenting my critical analysis on a public health framework for integrating ketogenic metabolic therapy in the prevention of major depression, bipolar disorder, and schizophrenia. So instead of reading this lay abstract word for word, I'd like to give a background of kind of what I'm going to be talking about today. I'm going to go over a prevalence of 3 serious mental illnesses: major depressive disorder, schizophrenia, and bipolar. And I'm going to be talking about the use of the ketogenic diet and the prevention and treatment of these illnesses, along with my literature review focused on taking these results and incorporating them into a public health framework modeled after the social ecological model. So some background about these 3 serious mental illnesses. Major depressive disorder, bipolar disorder, and schizophrenia all have similar risk factors, including family history, trauma, stress, and drug and alcohol abuse. A shocking total 11% of the US adult population has experienced these in the past year. I'm a very visual person, so I decided to, 11% of the US adult population, what does that really look like? Well, the US has 258 million US adults, which means 28.4 million of these US adults struggled with these severe mental illnesses in the past year. That's over the entire population of Maryland, Virginia, Pennsylvania, and DC. It's a lot of people we're talking about here. Perhaps even more concerning is that of this 11%, 30% of them are classified as treatment resistant, meaning they're defined as refractory, which means that they've had 2 or more pharmacological drug treatments that have been unsuccessful. So we've got 8.5 million people that are suffering these major conditions without an available treatment for them. 8.5 million people. That's greater than the population of New York City. However, it's not all bad news. There's hope in this field based on a new connection between metabolism and mental health. Both Stanford and Harvard just launched their own programs to study this further. What piqued my interest was a study that came out of France, where they looked at 28 inpatients suffering these conditions of bipolar disorder, major depression, and schizophrenia, and they put them on a 4-month trial of the ketogenic diet. The ketogenic diet looks at 80% fat, 20% protein, and about 5% carbohydrates, and it basically switches your energy source from burning glucose and sugars to burning fat for ketones. The results of this pilot trial were pretty substantial, looking at 43% of participants achieving clinical remission and 100% of symptoms improved in the patients. This early news got me excited to look more into my literature review to identify how this metabolic mental health research and interventions can be integrated into a public health framework. So the second aim of my study was to establish a framework of strategies, tools, and recommendations for how this can be incorporated into mental health care and using the social ecological model. The methods I used were 2 databases, Scopus and PubMed. I used 25 unique keywords to look at 18 search combinations. And I excluded the research published prior to 2014, and I excluded studies focused on children 17 years or younger. It was important for me to include research focused on epilepsy because the ketogenic diet has a history of medical efficacy for stopping seizures since the 1920s. Going further into my results, I had 925 results, 487 of which were duplicates between the 2 databases. Of these 441 unique articles, I assessed 157 full-text articles, and I chose 16 articles, including 3 sources of gray literature. I then categorized these results into 4 categories, the first of which being metabolic and mental health outcomes. The Stanford Medicine trial, which was released the results in March of 2024, so very current research into a 4-month single-arm intervention with an outpatient population for diagnoses of bipolar disorder and schizophrenia. Of these 21 participants, 79% of them achieved clinically meaningful psychiatric improvement. They also experienced metabolic biomarkers, decreases in weight, decreases in average waist circumference, and 100% of the participants who were defined as having metabolic syndrome were in remission by the end of the study. The adherence was looked at as 100% of the participants were classified as fully adherent, meaning their ketone measurements were above 0.5 millimeters 80% of the time, achieved a recovered state according to the clinical mood monitoring definition. There's also many case studies looking at the dramatic decrease in psychiatric symptoms, results on the positive and negative symptom scale, significant metabolic weight loss, and in some cases, successful taper off of all psychiatric medications. And there was a couple case studies that looked at 5 and 12 years of people that have been using the ketogenic diet to maintain and complete remission of their symptoms. The article also found a study of depth of ketosis, which looked at a patient that was showing stronger signs based on how deep that they were, the intensity of their ketosis. And it also found a case control study which looked at the energy demands of patients with schizophrenia, having them higher energy demands than patients without schizophrenia. The second category was based on future feasibilities. I mentioned there's kind of small trials right now, pilot studies, but the University of Oxford is poised to do a larger randomized control trial looking at the treatment-resistant depression. The review kind of came over with their protocol on that, and then a pilot study looking at the adherence rate of patients with bipolar disorder. The third category looked at public education programs, family support, and dietary adherence. There's a really cool psychoeducational program called Ketoland, which basically walked a family through the changes that they would need to support their daughter with a ketogenic diet. There's also studies looking at behavior change techniques and motivational interviewing, and a lot of the studies incorporated health coaches to increase adherence. Adherence questionnaires such as KetoCheck and iKetoCheck were validated tools that were used in Brazil and Italy to enhance ketosis and increase adherence. The fourth category used was screening and assessment tools. The key findings here were metabolic assessments and psychiatric assessments. Clinicians were looking at the patient health questionnaires such as depression scales, sleep indexes, clinical global impression scale, measuring the severity of symptoms, and then quality of life scale, among others. Metabolic assessments were also looked at, such as classic vital signs, BMI, waist circumference, and then measurements of ketone monitoring and glucose levels. So the second aim was to take all of this exciting new research and put it into a public health framework for prevention at a public health level. I did this based on 4 factors, looking at the social ecological model. The first factor is individual recommendations. A case control analysis showed the relationship between poor metabolic biomarkers and the risk of psychiatric disorders. Recommendations for individuals would be to encourage positive food choices, prioritizing a consistent sleep schedule, and participating in regular exercise. By encouraging programs that promote self-efficacy, we can empower behavior change. The second recommendations focused on the relationships. The consensus guidelines were developed for epilepsy, which is a standard in epileptic treatment to use the ketogenic diet. Additionally, training for clinicians with continuing medical educational classes will incorporate the relationship and take a proactive approach so that people can continue to have a year-long relationship with their providers. From a community standpoint, local leaders, school boards, and primary care providers can encourage preventative health purchases with HSA, FSA accounts, doing things to improve the physical and social environment. by primary care providers taking an involved view of this mental health and metabolic connection. They can screen for metabolic biomarkers that can put patients at risk for understanding those who are at risk for serious mental illnesses. Additionally, in-person and virtual support groups can foster a sense of identity, community, and accountability, which could lead to greater adherence and self-efficacy. From a society standpoint, there's a need for public health communication, more coverage in mainstream media outlets. There's groups like Metabolic Mind, which are doing nonprofit advocacy, and there's people that are sharing their personal stories of treatment through these interventions, as well as clinicians sharing these results. From a public policy standpoint, it does seem far away, but I felt that it was important to talk about public health in a way that if this does become a modality of treatment using food as medicine, we need to focus on the sustainability of our food system, focus on how we're going to manage billing codes for things like grass-fed butter, things like who's making the calls on all of these decisions, what is billed for, what isn't. There's a lot of minutia within there. Some strengths of the program were the tools and the precedents that were set based on other neurological conditions and epilepsy, and limitations were that the study was not limited to the US population, as well as the nascent nature of this topic. So in conclusion, I feel that we are at what could be a turning point in the public perception for how we prevent and treat serious mental health conditions, a point where larger randomized control trials are on the way, and the word is getting out about significant mental health and metabolic improvements. Through adherence tools, we can foster community relationships a community can foster an environment, and as a society, we can shift our view and support long-term policies to give more hope for a large population that has struggled for far too long. Thank you.